of the role of the ambulance service in this context. I appreciate being involved and engaged. If I try to provide a very succinct and concise assessment of what we're about, what we do, our mission, our purpose really is to preserve life, to prevent deterioration, and to promote recovery. And in essence, that's what we do in every patient interaction. That's what guides our staff. It's there from the inception of their journey with us when they join the service, through their training, and it really directs just about every patient interaction that we have. Underneath that then we have values which we seek to espouse to provide common ground: respect and dignity, a commitment to quality of care, compassion, improving lives, the concept of working together for patients, and the recognition that everyone counts. And we have created a symmetry between our values and those from the NHS Constitution, purposely because there's a lot of carry across, and we feel that they fit us very well. We face challenges as a service. Our demand is increasing year on year. It has done, it's doubled in the time since I joined the service in 2000. It's more than doubled in that time. It's rising at around about 3 to 5% per year. We get to more patients more quickly than ever before, but it is a challenge to get to those patients within the and take account of the increase in demand. In the service we provide, we're directed by clinical urgency, and that really is a priority for us. It's about identifying the patients whose need is greatest from a clinical perspective, and then tailoring our service to respond to that, while seeking to provide a reliable and quality service for those with a less urgent but no less important need. But it's about always trying to ensure that we can anticipate and respond to those most in need. In an ED context, some key points which I think will be carried out, brought out through the discussions. We have particular standby arrangements in place for patients with a very clear and perceived clinical need. So if there is a patient who is at immediate risk of death, or whose condition is particularly severe, we can and do alert the hospital receiving department in advance of our arrival. We do that through the communications facilities and elements, through our control room, and we seek to then expedite and smooth the flow of that patient through the ED department, and that works relatively well, in fact very well. Particular arrangements in place for stroke patients and also for cardiac patients. Another characteristic of the ambulance service, which perhaps differs from others, is that in essence we have a one-to-one relationship with the patient until handover. So when a crew is with the patient, they're with that patient, and their focus is entirely on that patient until such time as they hand over to the ED nurse or the receiving clinician. And I hope we'll get an opportunity to describe some of the more recent developments: new handover triage arrangements in the Belfast Hospital, hospital ambulance liaison officers, the use of information, and where necessary the use of hospital diverts to try and smooth and equalise the flow of pressure on the system. But you've done the introductions. Do you want me to elaborate on the introductions, or are you content that we leave that now?
If each of you want to very quickly describe your roles, that's fine, yes.
Okay.
Okay, good afternoon. I'm Brian McNeill, and I'm the Director of Operations with the Ambulance Service. I've been with the Ambulance Service now about 30 years, and I've done most jobs within the service. So that's...
Yeah, okay.
Good afternoon. My name is Nigel Ruddell. I'm the Assistant Medical Director for the service, background as a general practitioner, and where I still practice on a limited basis, and I would also work within the emergency department of one of the Belfast hospitals as well.
Good afternoon, my name is Michelle Lemon. I'm Assistant Director of Human Resources with responsibility for equality, personnel and public involvement, patient-client experience and communications.
Okay. Well, I maybe ask the first question, which is, I wonder if you'd just take us through what are the key resource and non-resource issues that are facing the Trust, and then how you are tackling them in practice.
Well, one of the key resource issues is the challenge to meet reductions in the budget. So since 2008, we have had two tranches of budget reduction, 4.5 million in the first 3 years, and somewhere in the region of 5 million, 4 to 5 million in the second 3 years. We have also managed to secure investment over that same period. And typically the investment secured has been linked to acute service change, so the closure of emergency departments or other facilities throughout Northern Ireland. And we have then identified a potential or a likely impact upon the ambulance service as a consequence of the closure of, for example, Oma or the Mid-Ulster Hospital. And we said we will be travelling for longer with patients in our care. That will mean that there's less resource available to provide cover and to respond where required. So we've then made bids generally successfully to secure extra resources. But because that's the limitation of the bid, the limitation of the investment largely in the service, the previous issue of increasing demand just from the ageing population, from the changing demography, means that we aren't essentially getting the additional resources to deal with the 5% year-on-year increases. And that again is eroding the capacity to respond. And in our trust delivery plan, which we've submitted to the commissioning board and the department, we've highlighted the risk associated with operating at ever greater levels of relative efficiency. Because the more efficient you become, the less scope you have and the less capacity you have to deal with fluctuation. And in our business, fluctuation is a key issue. We will see a spike in demand linked to a road traffic collision, linked to weather. It could be any number of things. And that then creates the greatest pressure probably that we see. The way in which we seek to deal with it, given the limitations on resources, is to balance and adjust our response to the non-critical emergency. So we will potentially delay our response to other calls, to lower priority calls, in order to preserve capacity for the emergency response. But that in itself presents the other side of the problem, which is, as well as bringing patients in, we are also taking patients out of healthcare facilities. And if we can't perform that function, then there will be congestion. Now, given the volume of patients that go through the hospital, our discharge is relatively low. We discharge relatively few people and we transfer relatively few between. But nonetheless, as I say, if you get closer to the edge, the fluctuations cause the problem in there.
Okay. Can I ask you something just on the prioritising lower critical calls? Puts quite an onus presumably on the telephone staff who are taking the call and who start by saying, tell me what the problem is. And those are not clinicians presumably, but may well be very experienced people in terms of the service. How does that work in practice? My ability to articulate either what's happening to my family member or if it's happening to me, I almost how do you ensure that the person is either not underplaying or overplaying what is happening to them?
There are a number of factors which I'll try and capture within this. The first is that we use an internationally recognised call triage system. It's Advanced Medical Priority Dispatch. It's based on the information that's conveyed by the call taker, the person who's making the call. Our call takers, as you say, are not clinicians, but they are trained in the use of that system. They have to pass a test and become accredited by the International Academy of Emergency Dispatch. So they go through a rigorous training program. One of the key elements of that is instructing them in how to take command of the call, and to immediately take command, and to then ask very specific and targeted questions, which are guided by a clear protocol, which is again internationally recognised. But the call taker will initially identify the location, and they will very quickly move to a series of questions which are designed to identify those patients most in need. So typically, is the patient breathing normally? Is the patient conscious? A patient who is breathing and conscious is considered not to be at immediate risk of life. If the answer to either of those questions is no, or I don't know, then we default to the position where there is a risk that the patient is therefore at immediate risk of life, and we prioritise our calls that way. That's what we target. So 50% of our emergency calls currently are categorised as potentially immediately life-threatening, but in actuality it's probably closer to 10 or 15% given that we're basing our initial assumption on, as you say, a symptom being conveyed by either the person or a third party. But that gives you an indication of the degree of protection built into the system.
Yeah.
So we then are targeting our resources at roughly half of the 999 calls coming in as an immediate life-threatening priority. While when we identify the location, we immediately task an ambulance to respond. Within 30 seconds, maybe a minute, we've identified then whether it's life-threatening, non-life-threatening, or potentially life-threatening, non-life-threatening, and we then reallocate the ambulance as appropriate. So we will either say continue because it's potentially life-threatening, or potentially if it's not, then you may say, okay, stand down and we'll preserve cover there, and we respond from something further afield. One of the other factors which we have is that the call takers, as well as being trained in clinical assessment, are also trained to provide online clinical advice over the telephone. So if you're in the patient's in cardiac arrest, there's a bystander, they can be instructed in the provision of cardiopulmonary resuscitation. Similarly, if it's a person or a child who's choking, the call taker can instruct in clearing the airway using the Heimlich manoeuvre. And we have had examples, and they've been played out in the press, where that call line advice has been demonstrated to have had a very positive impact on the patients. And that then gets fed back to the call taker to reinforce that they are a key element in the chain of survival. It's also very important that our own paramedics convey that back, and I have had compliments from paramedics which says the actions of the call taker clearly in the time it took me to arrive made the difference in this call. I don't know if I've covered all of it.
The only other thing I wanted to ask you is, you said with the key challenge of the resources, you said you've covered a bit of the non, but what are the kind of key non-resource challenges, the issues that are not necessarily immediately have to be remedied by money, but that are facing you as...
Engaging with our staff and our patients. We would go out as a team on station visits, but increasingly there's no one to visit because the crews are actually out on calls. It's now 50% of their time more that they are actually out on calls and therefore unavailable. So it's about changing that. Engaging with the public, because our element of the care pathway of the patient is a very small, 1 hour at the very beginning of what is maybe an average 6-day length of stay. So we have difficulties in that. I would say the other big challenge is integrating the various parts of the system. For us, it's actually difficult to use, for example, the health insurance account number, because in the kind of 999 environment, it's not a question you're going to ask the patient, can you read off a 9-digit number, even if you have it. It's about getting it there, but the absence of that 9-digit number means it's difficult for us to track the journey of the patient through the hospital and see what the actual outcome is. So it can sometimes be presented that our input is really limited to the time with the ambulance, but we would want to try and clearly show that what we do in that 1 hour or 1.5 hours has an impact right through the whole journey of the patient. One of the other difficulties is the variation across 5 different trusts. We operate as a single trust across the whole of Northern Ireland, and we seek to put in place, if you like, the one way of doing things, because our ambulance crews they're not restricted to working in the area in which they're based. If I have a crew which has travelled from Altnagelvin with a patient to Belfast to bring them to, for example, the regional cath lab, on their way back as they pass through the various towns on the route, they may well be assigned to a call in any one of 3 other trust areas. So we're constantly looking to try and get commonality of approach, irrespective of which service we're dealing with. That's one of the biggest challenges I think that we would face. Because again, in a pressurised environment like that, I don't want the crew to have to think, okay, what location am I in? Where am I now? What protocols do I apply? It has to be a standard protocol throughout, because really time is of the essence.
Well, I was going to ask you, it kind of brings me to my second question, which is the consistency across the trust as a whole. And I suppose what I'm interested in, two things. One of the issues that's been highlighted at this stage to us in Belfast is the difficulty of crews often having to kind of be on. You talked us through what happens when it's clearly critical, and there is a way in which you can fast track the person into the hospital, and people can be ready in advance. But where it's not at that level, and if an emergency department is overcrowded and you can't actually discharge the person into the emergency department, then that has ramifications for the patient, but clearly also for the use of your resources. How much of that is still a problem? Is it confined to one or two trusts? And my second question is, are there clearly, you get a chance to see a kind of EDs across the piece. What are the differences between what's going on, for example, in Belfast and beyond? What are the kind of issues? And I'd be interested in kind of an example of where, if you like, the service is not seamless because Trust A does something slightly different from Trust B, just to get a feeling for what that means in practice, where somebody is doing something different and the difficulties that causes you and your staff.
Yeah, okay. I think maybe about Brian to take that
Yeah.
one as Director of Operations.
Yeah, sure.
Brian was also, sorry for reference, also our lead representative on the RQIA investigation.
Yeah.
So I'm going to focus this answer basically on behaviour in ED departments across each of the trusts. I hope that captures what you're asking me. But I suppose, first of all, I guess we are and have been experiencing some issues in relation to handover at ED departments, and we have been working very, very hard to do that. Currently, the benchmark is that we would, from arrival at the ED door to hand over to the staff of the department, we allow 15 minutes, and then we allow 15 minutes for the crews to turn around to get stock back up again, get the vehicle back into its operating order, and be ready for the next call. So in 2010-2011, we were in standard for about 73.7% of the time. In 2013-2014, we were in standard 54.7%. So, and that is as a consequence regionally of, as the Chief Executive said, the increase in demand, but also as a consequence of the clustering that would be experienced over a 24-hour period, where we would see, for example, after noon and into the early evening, spikes in demand where we are now competing for the attention and capacity of the ED staff in competition with people who walk in or who are referred by GPs. So we would monitor our turnaround times, and we have been working with each of the trusts independently in trying to improve and source local solutions to local pressures. And we've also been working with the Health and Social Care Board in trying to find ways of both making the patient experience much better, but also releasing the crews back onto the field where they're required. So currently the loss of greater than 30 minutes cumulatively amounts to about 6.8 ambulances per 24-hour day. So in relation to what we have done, we have in place now, over the last couple of years, we've put in place hospital ambulance liaison officers. We have them in Antrim, Craigavon, the Royal and the Ulster. And these are officers who would work with the crews arriving on scene, and more importantly with the ED department themselves, in trying to ensure that where there are acute patients coming, that they know are coming in, which they will see, each ED department has a screen, arrival screen, which shows ambulance traffic en route, so they can anticipate what traffic is coming to each ED department's way. They can work to create capacity on the floor, and they can also work to create capacity by organising discharges from wards to allow the patient flow to be improved. So that was a key initiative. We experienced least problems in the Western Division, particularly in each of the hospitals in the Western Division. And that's primarily because they tend to resolve their pressure issues themselves, and obviously they have less activity, but that's our least problematic area. most pressures would be experienced in the big centres, the Ulster and the Royal and Antrim being key. Again, we have in our control room a new initiative, which is a dashboard, which is an electronic feed from each of the ED departments, and it shows the status in real time in terms of the number of patients that are in the department, the times they've been waiting, the potential breaches, and that also includes our information in relation to the number of ambulances that we have arrived and the waiting time or the turnaround time for the ambulances. That information has allowed us to anticipate pressures before they actually realise, and enables us to have intelligent conversations, if you like, with bed managers and managers within the ED departments. And from that, we could, for example, if there was a pressure mounting in the Royal, we could arrange to bypass the Royal for a couple of hours to allow them to deal with their pressure and release some capacity, and then switch it off in a couple of hours and get back to normal. We do that quite regularly. And I think one big benefit of that kind of intelligence and application of the intelligence has been the significant reduction in bypasses. So emergency 999 bypasses from ED departments, which are last year I believe we had 2. Years previous to that, it was a very complex process, and there were quite a few. Now 999 bypasses, because of the clinical seriousness and potential risk with them, can only be agreed by chief executives between the service and the trust. But as I say, we are able to, using other methods, to bring that down to almost a rare occurrence. But those are basically the measures that we have put in place, but it still remains a problem for us. What we have done is we have brought more turnaround times in under the 30 minutes. We have brought more in under the 30 minutes because of the increase in numbers. It doesn't show statistically, but we have minimised delays that were really quite significant in the past, delays of up to an hour or 2 hours.
Okay. And one more question before I hand over. The health service is now very target driven, and it strikes me it must be quite frustrating that I suspect your failure to meet some targets will be to do with issues within your control. But it strikes me that quite a number of the struggles to meet targets will be failures of other parts of the service, and much more difficult for you to have any control or even perhaps at best influence on. So is that a fair comment, and is that a frustration, and how do you deal with that? Or how do you say to staff, well, you didn't turn that round in 30 minutes? Well, if you were stuck because you couldn't get the person into ED, you may well have been champing at the bit to meet your target, but there's nothing you can do about it for reasons that are beyond your control. Most certainly there are factors that are beyond our control and do present as significant pressures to the trust. However, I will say at the outset that the trust is not driven by targets. So, for example, for every treble 9 call that comes in, we will endeavour to send the most appropriate response in the quickest possible time, irrespective of where the location is or what the target is or whether they're meeting it or not meeting it. Secondly, I will say that we do work closely with the other trusts who have got major pressures themselves and sometimes rely on us to support them. For example, when Belfast were doing the ED changes, we put in place extra resources with non-recurrent funding until they got to a point where they were able to get a solution, and then fortunately they provided us recurrent funding, which has now become embedded. The pressures themselves can present to us in other ways, in that, if crews are in ED departments and not out dealing with calls in the prioritised fashion that the Chief Executive has described, then that then results in, for example, simple things like inability to stand them down for rest periods and working over their time. But and they are really challenges for us currently, and quite rightly so. And it means that we have to think now innovatively of how we structure our
shift patterns and deal with peaks in demand and deal with these new pressures that have emerged. But most certainly, it's as much about working in partnership with the trust to ensure the best possible outcome for patients, but it's also about working and thinking outside the box in order to manage the duty of care that we have to our staff, and that's the biggest challenge that we have at the moment.
I could maybe just add, I think you're quite right. It is very frustrating when you're seeking to provide the best service you can, and there are aspects of it which you're not in control of, but it's about seeking to influence those to the best of your ability. So we fought very hard to actually secure the position of the 6th trust, the only regional trust. We fought so that we are engaged at the right levels. So I'm represented on the Chief Executive's group, Brian's represented on the Director of Performance, the Medical Director is represented with the Medical Directors group and the Chief Medical Officer, so that the ambulance perspective can be given, can be shared. And I think there's currently the Ministerial Unscheduled Care Task Force group. We're involved in that quite clearly and directly. And what we're saying is, let's make sure that this is about more than just 4-hour and 12-hour breaches, because the patient experience is determined by more than just a 4-hour and 12-hour breach. And you're quite right. The flow of patient from the door right through, including when they're with us, is a key part of all of that. So it's about conveying to our staff that we are engaged at those levels and we are actively seeking to change things. The introduction of the hospital ambulance liaison officers, one of the other key developments is the introduction of a protocol for handover of patients in a non-critical condition to the reception, so that they are managed and treated in line with their clinical condition, and they don't see they're treated with other people who may be self-present with the same clinical condition. So there is a degree of equity and fairness in the whole system, and it's about improving the flow through those. But I think we have to take a bigger view than just the target. And if the targets are going to be of any value, they have to be meaningful. So I've said as well, in terms of 4-hour and 12-hour breaches, where's the clinical assessment associated with that patient? Because not all 4-hour or 12-hour breaches have the same clinical determining need. And I think our first priority, as we would say, would be, let's make sure that those with immediate clinical need are flowing through.
Okay. Marion, pass over to you.
Before I ask only one question, before I ask, can you pick up on something, Brian, you said in response to Leslie's question? You were saying that there's an increase in breaches in relation to staff getting their rest breaks. Does the ambulance service monitor the staff and also staff's ability to get meal breaks? And if so, what are your findings on that?
Okay. Well, first of all, I have to say that our frontline staff, our emergency staff, under the current terms and conditions, are paid during their meal break. So we have an arrangement whereby we can disturb them if they're on a meal break to respond to a call, and that's their current terms and conditions, and their working week reflects that reduction in hours. But having said that, as a reasonable employer, we certainly want to stand them down for rest periods, and we have local, first of all, in relation to breaches, there are few breaches in terms of missed breaks completely. There are a number of incidents per day where staff would be outside of what we would desire to be the window of having a break, for example, 11 in the morning till 2 in the afternoon. However, we compensate them for that both in payment and in ensuring that they are stood down after that. In relation to what as an employer are we doing to address that, just at the summertime there, well, first of all, it's a subject that's on the agenda with staff side to try and put in place measures to address, for example, introduction of new shift patterns which would stagger, not everyone requiring breaks at the same time, sourcing funding to bring in staff part-time perhaps during the meal break window. So there are various measures that are being discussed through that forum. But we also, in the beginning of the summer, worked out a set of guidelines and rules to try and minimise as far as possible the occurrence by offering staff to take breaks, for example, at the hospital, as opposed to having to go back to the station, because we know that there's a high probability that they won't get back to the station given the demand, and a range of other issues. So we've been quite proactive in terms of ensuring that they are stood down for rest breaks. But as I'm sure you can appreciate, if the 999 activity is very high on a particular day at that particular time. And I have to say, and some staff are very innovative themselves. They will take their meal with them and just, not take the full time, but just get a cup of coffee and a sandwich and then ready to go. But it is a pressure for us, and we do recognise it.
Thank you. Coming to the question I have, it's really about how the ambulance service deals with particular groups, and you've heard me ask that of Ulster Hospital staff. And I'm just wondering, in terms of the ambulance service, when you deal with patients who have particular needs, those with mental health difficulties, drug addiction, children, or patients with a degree of dementia, what sort of problems are you facing, and have you identified any approaches that would improve the service that both the ambulance service offers to those groups or the receiving emergency department?
Maybe look to Nigel to start off with that one.
First of all, at the start of the process, when we receive a call from either one of these patients or somebody calling on behalf of one of these patients, Liam alluded to our system of how we manage the call. The AMPDS system, the triage system we have, is designed to cope with communication difficulties from patients, to make sure we can get the correct detail from the caller, to be sure that they are prioritised on an equitable basis, so that they receive the same kind of response regardless of their ability to engage with us. Throughout the training, our crews will receive education on all the particular topics that you mentioned: the care of children, the care of the elderly, the care of those patients with mental illness, the care of the dementia patient, etc. And in truth, when we present with a patient at an emergency department, as Brian has alluded, it's not in our best interest for an ambulance to be tied up for a long time. But we recognise how busy the emergency departments are. We recognise it's not always possible to be able to hand a patient over within 15 minutes. And when that is the case, our crews, through good practice, will remain with the patient. We feel strongly that on arriving at the hospital, the responsibility for a patient does become that of the hospital, but nonetheless, for good practice and for the safety and comfort of the patient, our crew will remain with them, managing that patient on a one-to-one basis, to ensure their needs are met, to ensure their safety, ensure their comfort and dignity. And they will act as an advocate for the patient, liaising with the triage staff at the hospital to bring to the attention of the receiving staff particular needs that patient may have at the time of handover. Liam mentioned taking a regional approach. Over the summer we have been doing work to get a regional approach to how we pre-alert a hospital to particular conditions, when that should be done, and the information that is passed at that time, and also the process of handover itself, to make sure that vital information such as that I've already described is handed over in a way that is consistent and that is taken notice of, so that such people do not fall between the cracks in care.
I'll pass you to Paul.
Thank you very much for your time this afternoon. Liam, I'm really pleased you mentioned the National Health Service Constitution. I think you're the first person who has, and it's a good place to start, so thank you for that. Michelle, please excuse me, I didn't catch your job title.
I thought you might be interested in.
Yeah. Could you repeat it for me, please?
Assistant Director of Human Resources, but the area of responsibility that I have covers equality, personal and public involvement, patient and client experience, and communication.
Okay, thanks. So I'll come back to you if I may. Thank you. We're interested in, as you know, a human rights-based approach, really, a human rights-based approach to emergency care, and that's about the human rights of the public and patients and the human rights of health professionals. including the terms and conditions of work of health professionals, and that would include looking at fair work-life balance. And in that context, I was really interested to read the Health and Social Care Staff Survey of 2012, which I'm sure you're very familiar with, but just to make sure that I'm getting it correct. So there was a question about whether or not staff felt their organisation was committed to helping balance work and home life. And amongst overall health and social care staff, 44% felt their organisation was committed to that. But when it came to NIAS staff, it was only 13%. So I'd be interested to know whether there's evidence that things have improved since 2012, whether or what actions have been taken to try to address that, and if there have been actions, how they're monitored and how this problem is monitored. I have some other questions, but let's start with that one. I don't know who to look to. I'll leave you to say.
I think quite early, the staff survey did and does present challenges to us, so we've developed an action plan to address it. It's a 3-year action plan, and we will look to cover the range of issues in it. I have to say that the work-life balance doesn't feature in the first instance of it. However, that doesn't negate and prevent us from moving forward with some of that. Certainly from engagement with staff representatives and indeed with staff themselves, including my most recent visit to emergency departments last week when I was down talking to some of the crews, I would suggest, my sense is that the big work-life balance issues for them are getting their rest periods, finishing on time when they expect to finish, and getting their leave when they expect to get it. In reverse order, getting their leave, we have procedures in place. We actually roster most of the annual leave, about 60% of it, 30%, 40% of it is sort of self-rostering, it's scheduled, and it will be subject to the exigencies of service. And as you may be aware, in recent weeks, probably over the last 4 or 6 weeks, we've had big challenges in that area. Not just in that area, but that was one of the factors leading to us losing cover, and we have revised our practices and processes to address that. I'm pleased to say that we're back towards the 90% cover. We've equalised it across the working week. There was a particular problem with weekends, which is when most people were looking for their leave, not unexpectedly. So we need to take that learning and then apply it as we go forward. But as we're coming out of the rostered leave period, we'll be creating the time for that. So, I mean, as an employer, we are anxious and keen to ensure that we meet staff's wishes as well as the needs of the public, but it's a balance between the two. In terms of the late finishes, Brian's already mentioned some of the discussions which we're currently having in relation to start-finish times and staggering shifts. If I have 10 crews who start at 8 a.m., I am looking to give a rest break for 10 people within 3 hours. If I start finish times, so the 2 of them start at 6, 4 of them start at 8, and 4 of them start at 10, then I've now created a 7-hour window within which to give 10 people a break. And that makes it easier for the staff in the control room who are seeking to manage the response to the call. So we'll engage with staff around that. There will be engagement and interplay because staff are accustomed to starting at a particular time and they have built a program around that. But this is one of the challenges we're working through. And then in terms of the rest periods, yes, rest periods would be next. Again, we're looking at that to say, okay, so how do we, we're starting the breaks for the rest periods. Slightly getting lost in myself here. Breaks, rest periods, start and finish times, yes, the two are intertwined. That's one of the measures, but there would be a range of measures by which we'll do it. But in terms of other work-life balance, we have a range of policies in place which can be accessed by staff. But one of the key issues which we do have to address, and recognise we have to address, is filling current vacancies. Because if we fill our vacancies, we then have the cohort of staff to enable others to engage for term time working and others. We have facilitated term time working this year. We have facilitated other aspects of work-life balance, and indeed, when we introduced the work-life balance policy some years ago, They were actually put forward by one of our trade unions and won a regional award. So I think the basis for what we're trying to do is sound. The application will be conditional upon us turning some vacancies into full-time posts. Not to make any excuses, there have been difficulties in the past in translating non-recurrent funding into recurrent funding. Recurrent funding is what I can use to recruit to permanent posts. Non-recurrent, I have to look to other measures. But what's been clear from this summer is that a previous reliance on overtime from our staff is no longer sustainable. Even in previous years, I was achieving and continue to consistently achieve 95% coverage shifts. That dropped because there was a move away from overtime working. And it's about recognising that we've adjusted, as I say, we've put other measures in place which have reduced some of our reliance on it. However, the big difference will be the recruitment campaign which we're currently engaged in. So we've recruited to paramedic posts. We're recruiting over this weekend last for technician posts. And I hope from that we will stabilise and consolidate our workforce. So that's probably the key piece of it, I think.
And how's that being monitored, Liam? What would be the monitoring mechanism for this issue of fair work-life balance?
I think what we'll be doing is looking to see, well, one of the ways in which we monitor at present is that staff are notifying us when they have their meal breaks spoiled or missed or indeed delayed, and we are looking at those reports, and a reduction over time relative to the workforce would be one measure, and it's one measure that we actually are seeing over time. But I want to move away from a reliance on staff having to notify to build it into the systems. So our systems record and date and timestamp just about every interaction we have.
Right.
So I want to then say, okay, let's make sure that we're recording when staff are placed on meal breaks, when they're interrupted, if they get an uninterrupted break, and have a very sort of concrete and robust system which is drawn from the vehicle log effectively, and says, well, we know it happened because when you arrived, you pressed that key, and that meant you were on a break. You pressed that key, you were off a break. So there's less sort of interpretation involved in it.
Can I maybe just add,
Sure.
one of the issues that came up as well through the staff survey was an issue around communication, and one of the things that we are looking at the minute around work-life balance is really looking at the systems that we have in terms of when staff apply for a work-life balance policy that Liam's referred to. So for example, they want to work part-time, they want to maybe take a career break, whatever, and looking at the rates at which people are applying and the extent to which we're granting or not granting those. That's something we haven't been monitoring to date, and that's something we're looking at doing. And then also looking at how we communicate that to staff and make them aware of really what is already there. I think individual members of staff can request flexible working, term time working or whatever, but they don't maybe see the overall picture of what we're doing as an organisation. And the disappointing thing, I think, in the staff survey that you referred to was maybe not a recognition of our level of commitment to that, and that's something we need to reaffirm.
Can the RQIA, is it empowered to monitor this sort of thing? I mean, has the RQIA prepared a report on this issue in your service, the issue of terms and conditions of staff, of work-life balance?
Not that I'm aware of. I don't know. You probably need to ask them whether they can do it or not, but I'm not aware they have done.
Okay, thank you.
Can I ask a cheeky supplementary before you do your
Yeah,
next
sure.
one? Do you monitor levels of sick leave and use those as a proxy for staff having difficulties with work-life balance?
We monitor sick leave. I'm not sure that we would use it as a proxy for work-life balance. I think the attendance policy that we apply is really geared at identifying on an individual basis the individual reason for the illness and then managing accordingly. The most common reason for absence in the ambulance service is musculoskeletal injuries. So most of our response has been around introducing enhanced and rapid access to physiotherapy, access to occupational health, and then working through line management.
Just out of interest, what's the average number of working days lost amongst the ambulance staff and the non-ambulance staff?
there's currently an issue with the calculation of sick of absence because we've moved to a new system with the whole HSC. But up until last year, I think our absence was running at around about 7.8%. I suspect it has increased this year, but I can't actually put a number on it because of the change of system. But we apply the same regional policies and procedures in relation to it. But as I say, we have put in additional measures for recognition of musculoskeletal injuries, and we've access then to care call and other facilities for staff who suffer trauma.
Do you see the musculoskeletal injuries? I mean, we're all told we're all getting better, and we all know that's the case because we don't fit into things we used to fit into. I mean, ambulance personnel are having to deal with people who have problems with obesity. I mean, are there any arrangements in place to reduce the likelihood of damage to people's backs, etc.?
Yeah, there are. In my previous post, I was the head of training, and during that time, I've been working on a project with colleagues in reviewing the equipment that we were using, and we brought in a number of new moving and handling aids, which has helped. We also introduced a training course, which was used nationally now, an accredited course for moving people, and that has helped reduce musculoskeletal injuries. And we also have been very innovative in the design of our vehicles. So all frontline vehicles and would have tail lifts to avoid having to, in my day, lift a stretcher up that height. And indeed the PCS vehicles, or patient care civil vehicles, have either got a ramp or a tail lift as well. But I think the key issue here is, as you have suggested, it's when we get the patient from a hospital, for example, a transfer from a hospital to another hospital, we can apply all of those aids and do well in doing so. If someone is up 3 flights of stairs, then unfortunately some element of effort has to go in, and that's where the risks are most, and that's really where we find most of the problem.
Thank you.
Can I just, if I could just finish a couple of questions, but I'll have to be very brief now, and I'm afraid you will as well, because I think we're out of time. But I just wanted to refer to the Compton Review of 2011, and there's a passage in there at page 101, which says it will be important that the NIAS can transfer people not only to accident emergency, but also to urgent care centres, minor injuries units, or GP out of hours. Bypass protocols, and Brian, you talked about protocols, bypass protocols will be required, which clearly define which location patients should be transferred to for each type of condition. And you talked about bypass protocols, I think in a somewhat different context. So I would be interested to know if it's possible to inform us briefly whether or not this Compton Review, effectively recommendation, whether this is in hand, bypass protocols will be required, defining which location patient should be transferred to for each type of condition. And then later on, the same page, Compton says it will be essential that the public are provided with information about the correct procedures in an emergency. I'm not 100% sure what that means, but I'm sure you do know what it means. I'd be interested to know if you have any comment on that. And let me put in my last question, because we're out of time, to you, if I may, Michelle. And it was the participation, public participation element of your job description that I'm interested to hear a little bit more about. Thank you.
Okay. To be succinct, I'm not entirely sure of the context for educating the public on how to use emergency. I need to go back and look at it, but there was certainly an issue within Compton about simplifying access to unscheduled care, of which the emergency is one component. So you know in England they've introduced a single number 111 to introduce simplified access to unscheduled care. The police service here have introduced 101 as a means of doing similar kind of thing. Within the ambulance service, we've been advocating that there's an opportunity which needs to be explored to potentially simplify access. Very conscious of the fact that of the patients who arrive at the emergency department, we would transport somewhere around 35 to 40%. So there's about 500,000 patients a year who arrive at the emergency department not by ambulance and not necessarily having seen someone else beforehand, and if there's an opportunity to provide them with the means to get advice, guidance and support to manage their condition differently, then I think we need to explore that. That to me is the means of emergency access. In terms of the minor injuries, we have worked with the Commissioner to introduce a range of alternative care pathways which are designed to, where appropriate, manage people closer to home or at home, or either taken to a different destination. Nigel's been leading on this. We have the minor injury pathway in place in Omagh. That was the first place. So the Urgent Care and Treatment Centre in Omagh, the staff there and in the Western Trust worked with Nigel and Dr. McManus to identify patients appropriate to take to Omagh instead of either to Altnagillan or the Erne, which means that they can be treated closer to home. The key to it is that the hospital, the Urgent Treatment Centre, the Trust advises us that they are ready to accept these patients and it's safe to bring them there. Because our presumption up until now has been it is not safe to take a 99 patient to that treatment centre, but to take them to the 99. So when we're advised that it's safe to treatment, take them there, we have the protocol already in place, operating in the West, and we can roll it out to any of the other areas. That protocol has been shared with all 5 trusts. The protocols which guide the Urgent Care and Treatment Centre have been shared by the Western Trust with the other 4 trusts. And basically, we stand ready now, when we're advised and we're engaging individually with each of the trusts, we stand ready now that if we're advised that it's safe to take them to an alternative centre, we will issue the protocol to our staff and apply the regional protocol in that area.
Thanks.
Does that help?
Thank you.
Thank you.
Michelle.
Okay,
Yep.
so the issue of participation is a challenge for us, given the reference Liam made earlier to the fact that our patients are with us for a very short window when you think of the time spent in other elements of healthcare. They are also with us at a very traumatic time. They leave our care and they go into the system, and very often we don't know what happens after that. They may not be conscious with us, we may not even have their name. So it can be difficult for us to then follow up and have kind of a group of ready people that we can engage with. But we try to do really 2 strands of participation. One is where we're trying to get feedback from people who have been in our system, and one is where we're proactively going out when we're looking at how we change and improve our services to involve the community as far as we can in those changes. So in terms of feedback, we work with the other trusts around the patient-client experience standards and 10,000 voices, and try to get some feedback around how things can be improved. To do that, we very much link in with their surveys, try to have a bit of a pragmatic approach to it, because our patients are their patients, and it wouldn't make sense for us to go along and interview the same people that they've already done that with. In terms of the more proactive element then, if we are developing some kind of a new change, we've got a modernisation reform programme at the minute linked to the Transforming Your Care programme. We're going out to try and identify people who may be interested in our service. They may be people who've used our service. They may be people, Marion, who come from the groups that you're talking about, who very much are part of our demographic, who have something to say, and we try to involve them in the policy development bit then as early as we possibly can. And we also use that engagement then to inform the screening of the policy. So through section 75 we're looking at equality screening, and we build human rights considerations into that as well, and so we use that engagement very much to inform that process.
Okay.
Is that public? Could we see that?
Screening template, absolutely.
Yeah.
Yes, sure.
I mean,
All the trusts use it, so we can certainly share
I'd be
that.
interested to see it for my education.
Sure, of course,
Would
absolutely.
that be possible?
Sure,
Yeah. No, that will be
sure, of
possible.
course.
Thank you very much.
Okay. Liam and colleagues, thank you.